think what's important is sort of to make sure we identify what we've learned about APS1, touch on the genetics and pathophysiology of the disease as we understand it now, and then briefly sort of overview the management and treatment, which we'll hear a lot more about in the next couple of days. So this is no surprise to everybody, but I think it's important to sort of outline exactly what APS as an acronym, we get tied up in acronyms sometimes, means. And of course, it's Autoimmune Polyglandular Syndrome Type 1. And as the name implies, that would suggest that it's really a problem with the endocrine system and your endocrine glands. But a lot of the discussion I think that I want to impart on today is that it can be much more complicated than that. And I think that has really important implications to the way we think about patients and the way we treat and manage the condition. So I think this is really well captured by going over a case. And I'd like to share a case with you of a 4-year-old girl with a history of low calcium and thrush. And really early on, she had problems. So at age 1, she developed recurrent episodes of diarrhea. Within the first 2 years of life, she had frequent upper respiratory viral infections and croup. She had been diagnosed with pneumonia. And as a result of that, she underwent a tonsillectomy. And during that peri-procedural setting, she developed seizures and difficulty breathing. So when the doctors assessed her, they saw that she had carpopedal spasms, or spasming of their hands and feet. She had a positive Schoffteck sign, which is hard for me to say, but and then Trousseau signs, which also indicate that she had low calcium. She had corneal ulcerations, thrush was apparent in her mouth, and she had small teeth that was deficient in enamel. They also noticed that on her hands that she had soft nails with ridges and pits in them. And from this single presentation, she had a total of maybe 6 different manifestations just at that young age. So she had hypocalcemia, hypoparathyroidism, candidiasis, ectodermal dystrophy, likely keratitis with the corneal ulcerations, intestinal dysfunction with the chronic diarrhea, and the respiratory infections could be a little bit more complicated, possibly pneumonitis, but also maybe laryngospasm due to her hypocalcemia. And I think this case, what was really surprising to me is that this case was actually first identified in 1929. And even at this time, even though we've come a lot further along the way in our understanding of the disease, this really speaks to evaluating the whole patient and not really making sure you don't miss anything. And so we talked about what the acronym means, but I think it's also important to outline that it comes under many other names, including polyendocrine syndrome type 1, and APECED, or autoimmune polyendocrinopathy, candidiasis, and ectodermal dystrophy. You can see why people just say APECED. And what that means is really the diagnostic, try to help individuals with the diagnostic criteria, which, as many people know, is really dependent on 2 of the 3 major manifestations in the classic triad, which include candidiasis, hypoparathyroidism, and adrenal insufficiency. And these 3 things, they happen pretty early in life in general. Candidiasis happens usually, is one of the first manifestations to appear, but not in everyone. And the other 2 usually happen for most patients within the first decade of life. And they're pretty frequent in the population. So if you take a look at patients with this disorder, many of them, 60 to upwards 70%, will have these 3 diagnoses. But what's important, and as our case earlier illustrates, they can have a lot of other problems, including alopecia, vitiligo, hepatitis, pneumonitis, and so on. This diagram I like is because it really shows the kind of breadth and tissue involvement of this disorder, and really speaks to it being much more than an endocrine problem alone. And so this slide may be familiar to some, and I think it's an important one to go over. Patients with this disorder can have a very broad spectrum of disease. Upwards of 30 different manifestations have been reported, and some patients may even have up to 20 different problems, all related to APECED. Once again, you can see that these 3 here are pretty prevalent, but within the patients that we've seen at the NIH, the GI tract, liver, skin, and salivary glands can affect up to 80% of patients. And they have many different manifestations even before their official diagnosis. On average, patients have about 5 different manifestations, but as I mentioned before, this has quite a range, up to 20, 25 in some individuals, and the majority of which are actually non-endocrine manifestations. So we wanted to take a little bit of a deeper dive into this and taking a look at the early manifestations from that spectrum of disease, and 3 really stuck out. A hive-like rash, which some people may be very familiar with, and we'll hear more about that today, intestinal dysfunction and enamel hypoplasia. And the thought was that and this is a slide really to illustrate those 2 conditions. On the left-hand side, you can see hive-like rash, which is actually fairly different than hives or urticaria in that it's not itchy. Usually it lasts longer than 24 hours. And on the right-hand side, you can see that this person's teeth are deficient in enamel. And so we wanted to really take a look at these other early manifestations that we found and compare that to the classic triad with the hopes of seeing if we can identify patients earlier. And so as you can see here, comparing the 2 Kaplan-Meier plots here, you can see that the adjunct triad, as we called it, with the hive-like rash, intestinal dysfunction, and enamel hypoplasia, occurs earlier on average than even the classic triad. And so we really wanted to compare that a little bit further, and you can see that by adding those 3 other diagnoses to the classic triad, you could accelerate the time to diagnosis by about 4 years, and hopefully in about half of patients identify the condition before they have a severe adverse event like Addisonian crisis or hypocalcemia leading to seizures. So we propose that in addition to the classic triad, we add the additional 3, or adjunct triad as we've called it, and any 2 of these 6 different conditions should lead to further testing. And that testing is done by confirmatory, typically genetic testing, which we'll hear a little bit more about the caveats and issues with today as well. And I think this is important to help not only specialists, like a lot of the people in this room who know very well about these types of disorders, but the general population of physicians who take care of patients and see pediatric patients in the clinic, to identify these other different manifestations as being a part of the disease. And that's because it's still a very rare disease. About 1 in 100 to 1 in 100,000 to 200,000 is the worldwide average incidence, but it is enriched within certain populations, as you can see on the screen. And I take a brief moment here to introduce the dominant negative mutation that's been reported, which can be up to 1 in 1,000, and we'll talk about that in a moment. But as you can see, depending on which country you're from, it can be a very wide spectrum of the prevalence, as much as 1 to 9,000, up to 1 in 10 million for those in Japan. Focusing on the United States, it's estimated to be about what we'd expect for at least the average worldwide, at least from some general calculations, about 1 to 100,000, up to 300,000 patients. But more and more information is coming in regards to that. And the reason that some of these other populations seem to have a higher prevalence of the disease is really related to these founder mutations found in those populations, with over 90% of those patients from those countries having these different homozygous mutations, or both copies of the gene with that variant. And so also to summarize in regards to the dominant negative mutation, you can see those 2 that are highlighted in red there. What's interesting about this is that it can be 1 in 1,000, as I had mentioned before. So far, we haven't seen any patients at the NIH, but we are actively looking for these sorts of things to see if we can identify patients as well. And what's interesting about this dominant negative variant, or also referred to as non-classical APS1, is that they typically have a much more mild phenotype. Usually their major manifestations are pernicious anemia, vitiligo, and B12 deficiency, as apart from what we have discussed earlier today. So I want to take a little bit of a step back and really summarize what underpins the pathophysiology of the disorder. And I think this is really attuned to it being an immune system problem. And you can see here that the thymus, which we'll learn more about today, is kind of where the T cells, or the immune cells in your body, go to get educated about what's yourself and what's not yourself. And there's a special cell that lives in the thymus called an MTEC, or medullary thymic epithelial cell, and air really works in that cell. And it makes copies, essentially, of different tissues, like your stomach or your eye or your lung, and shows it to these T cells to say, oh, you shouldn't attack yourself, obviously. So if it does encounter an autoreactive T cell, or a T cell that can cause autoimmunity, its job is really to eliminate that cell so it doesn't become a bad player outside in your body. It can also shuttle cells to a different subclass, which we call sort of a Treg, or regulatory T cell. And these cells are important for maintaining sort of homeostasis of your immune system and making sure inflammation gets quieted down when it needs to. In the setting of AIR deficiency, or mutations in that AIR gene, unfortunately that doesn't happen. And so these T cells come out into the circulation where they recognize these different tissue antigens and can cause autoimmunity. So overall, we've discussed a little bit on this, and we'll hear more and more about it in the subsequent sessions. But really the burden of APECED is that it's a multifaceted disease, and it really needs to be diagnosed earlier, and so that management and treatment can be applied sooner. And I'm going to just briefly sort of overview this slide, because we're going to hear a lot more about that in Dr. Leonakis' talk just coming up. But I think because it involves so many different manifestations, it really is served best through a team-based approach, working with patients and physicians amongst different specialties to really identify early and manage early before there can be significant complications. What this also entails is the comprehensive evaluation that we had introduced earlier, where patients come and we look ahead of time before there can be a problem in regards to these different complications that can happen or arise. And that really takes place through really proactive screening approaches. We'll hear more about this today as well in regards to strategies for candidiasis. And then a lot of it is focused right now, though things are changing in regards to hormone replacement and electrolyte replacement for things like adrenal insufficiency and hypoparathyroidism. And we will definitely talk about this today, and I think is very important and a very strong interest of mine personally, is when and how to institute immune modulation with hopes to really change the course of the disease over time and hopefully prevent further complications out later in life. So with that, I want to say thanks for you once again for me being here. I think the future is really bright, and we're going to hear a lot about the advances in research here, not only at this meeting, but also as we fit into the greater IDF community. For those of you less familiar with IDF, the zebra is sort of the mascot, and I think this really kind of it recapitulates where we're going to move forward with treatment and management of this disorder. So thank you so much. I'll take any questions. Absolutely.
Thank you so much, Dr. Constantine, for summarizing this disease so efficiently. I'm going to bring you up to answer questions, but just a note on questions. We've been asked if people could not identify themselves in their questions, and please don't identify anything about your diagnosis or your symptoms. Because the session's being recorded, they would have to then edit out any potential privacy issues. So if you could just ask your question simply, then that will make it easier down the road to get all of the recordings online. So any questions for Dr. Constantine? Yes.
What is the immunomodulation?
So the question, in case someone else couldn't hear it, is what is immunomodulation? And I think that's an excellent question, and thank you for asking that. What that really means is changing the immune system, sort of modifying the immune system so that these bad players in the setting really specific to APS1, these bad playing T cells that recognize yourself as a bad thing to attack, that we can somehow change them in a way to where they don't do that. And similar to other disorders that we've learned a lot from over the years, like rheumatoid arthritis, where if you institute medication therapy early on in the disease, you can really modify the course of that disease. So we know with similar autoimmune disorders, if you start something like, for that example, methotrexate, they do not go on to have serious complications that they would otherwise. And so that's really what we're looking forward to, and we'll hear more about today, moving forward with the treatment and management of APECED. Thank you.
Anyone else?
Yes.
Are we anywhere near in the future where it will be cost effective that when children are born they can just do blood work and test for all of the genetic disorders, the right off the bat?
Yeah, I think that's a really good question, and you bring up a very big horizon in regards to that. At the NIH, we have the luxury of, and then many of you are familiar with that, we do testing on almost every patient that we see who comes through the door. And I think a lot of other institutions are working towards something like that. Right now, I don't think we're at the capability of doing it at birth, but I think at some time in the near future, maybe in the next 10, 20 years, we will see programs like that coming out. We already do have things like newborn screening for specific immune deficiencies, like severe combined immune deficiency, which is a correlate to that. And I think, really the goal is to identify these rare conditions early and prevent them. We do that for some diseases, but I think, and we'll talk about that more today, strategies that can focus on not only from a genetic standpoint, but other markers of disease that might also be easier to detect, like interferon omega autoantibodies, which I'm sure we'll talk about more. Yes.
The keratitis is not listed as one of the early signs, but I keep reading case studies where keratitis, there are 2 3-year-olds in Europe that I read case studies of recently that was part of the markers. Is keratitis fairly common as an early?
It is fairly common. I think Dr. Leonakis may be able to speak a little bit more onto how early it typically manifests, but it is a very common manifestation that we've seen, at least at the NIH.
Would cord blood banking or bone marrow transplant play a role in auto modulation?
So that's a really good question, and for those of you who couldn't hear, the question was, would bone marrow transplant or cord blood banking for the purpose of transplant be helpful in immunomodulation? And I think it's a very good and challenging question. Just kind of to touch on the surface of that, in a way it might, but at least from preclinical studies in a mouse model, it doesn't seem that bone marrow transplant alone is enough to sort of modulate or to cure the disease. In that setting, they've actually done even co-transplant of the thymus, which we know that that's primarily where air is expressed in those cells in the thymus, and without sort of drastic changes, with removing potentially the original thymus in that patient, putting a different thymus in that has sufficient air, and potentially also a bone marrow transplant, that is a possibility, at least theoretically, for modulation or even cure of the disease. But I don't think bone marrow transplant alone would change the course. It's a good question.
In the earlier session, they were talking about gene therapy
Mm-hmm.
and maybe imparting a stopper for the expression of the gene. Do you think that with the air gene?
Mm-hmm. That's a really good question. I think it's an excellent question. I think it's possible, and the reason I say that is that there are a lot of advances in the realm of type 1 diabetes where they're doing direct gene therapy within the tissue itself. So presumably, it would be possible to impart a transfer of a wild type or a normal air into the thymus. The question is really how feasible is that, and at what age would you need to do that to prevent the autoimmunity from taking hold early in life? Because we know that even, at least in a mouse model, we know that the autoimmunity happens pretty early, and that these T cells have already gone to the thymus, they've gotten educated, and they may be out in the periphery even at the time of birth. And it isn't until later in life where they've caused sufficient organ damage where you see a problem. So I think it's a possibility, but we have to learn a lot more before we get there. Oh, yes, I'm sorry.
Thank you so much for your time. You mentioned the keratitis.
Mm-hmm.
What percentage of APECED patients actually have retinal dystrophy versus corneal?
It's common? Oh, it's uncommon, yeah. I have my phone a friend over here, I guess.
Retinal or corneal? Corneal, what about corneal problems? 40%.
Yeah.
40%.
Yeah, corneal is much more common than retinal issues, at least I've personally seen amongst our cohort. There are a few patients that do have retinal issues, but but it isn't a common manifestation overall. I don't know that a specific percentage amongst the cohort, but okay. Dr. Leonok is saying less than 10% for retinal problems.
Any other questions?
All right. Thank you so much.
Thank you.